Hello my dear friend. In this session, I will be discussing the very important part of the ECG, that is the ventricular arrhythmias. I am myself Dr. Rajesh Gubba, the educator for general medicine. So, first let me discuss what are the types of the ventricular arrhythmias. If you see the types of ventricular arrhythmias, we have what is called premature ventricular contractures, that is 1. Number 2, ventricular tachycardias, and then the ventricular fibrillation. So these are the types of the ventricular arrhythmias. Now first let me take up the discussion of the premature ventricular contracture. Already in one of my sessions I have discussed in detail about the premature ventricular contractures. In this session I'll just give you the basic definitions of premature ventricular contractures, what is ventricular tachycardia, what is sustained VT, non-sustained VT, and what is this ventricular fibrillation, all that we will be discussing now. So you take the premature ventricular beat or premature ventricular contractures. Both are same. Premature ventricular beat, it is also called premature ventricular contracture. Now this premature ventricular beat, it is the ventricular beat that fall earlier than the next anticipated supraventricular beat. So it is a ventricular beat that appears or that fall earlier than the next supraventricular beat. So that is what is your premature ventricular beat or premature ventricular contractures. And this particular premature ventricular contractures, let me tell you, they can be either unifocal, multifocal, or they can be in the form of couplets. Now what do you mean by the word unifocal? Premature ventricular contractures that originate from the same focus, right, that originate from the same focus is called as the unifocal premature ventricular contractures. And this unifocal premature ventricular contractures, they have the same QRS morphology. Right, they have the same QRS morphology and they are referred to as unifocal premature ventricular contractures. Whereas premature ventricular contractures that originate from different ventricular sites, that originate from different ventricular sites, that is what is called as multifocal premature ventricular contractures. And these multifocal premature ventricular contractures, they have different QRS morphology. So the QRS morphology of unifocal and as well as multifocal, the morphology is different, right? In unifocal, they have similar morphology, whereas in multifocal, they have different morphologies. Now, what do you understand by this word, the ventricular couplets? If two consecutive ventricular beats are there, they are called ventricular couplets. So, if there is presence of two premature ventricular contractures consecutively, they are called as the ventricular couplets. So these are the types of your premature ventricular contractures. And what exactly is the definition of premature ventricular beat? It is the ventricular beat that fall earlier than the next anticipated supraventricular beat. Now let me just show you the ECGs of the unifocal, multifocal, premature ventricular contractures. Now if you take these particular ECGs, you can make out that this is a premature ventricular contracture or premature ventricular beat. If you take the QRS morphologies of all the premature ventricular contractures, they have similar morphologies. And this premature ventricular contracture, it is appearing alternatively. After a normal beat, you have a premature ventricular contracture. And this particular rhythm is called as bigeminal rhythm, or it is called as the bigeminal frequency. And you take the second ECG strip. The premature ventricular contractures, they are of different morphology. You see here, premature ventricular contracture of one particular morphology, and you can see here the premature ventricular contracture of the different morphology. So these are called as multifocal premature ventricular contractures. And you can see here that premature ventricular contractures, they are appearing in the couples, or they are appearing consecutively. So this we can call it as the ventricular couplets. And if three premature ventricular contractures occur consecutively, we can call this even as the ventricular tachycardia. But only thing, in case of ventricular tachycardia, the heart rate should be more than 100 beats per minute. That is a very important criteria to call it as ventricular tachycardia. Now, let me discuss about other types of ventricular arrhythmias. One, premature ventricular contractures. What exactly is the definition we have discussed? Now, let me tell you what is this ventricular tachycardia, what is idioventricular rhythm, what is sustained VT, and what is non-sustained VT. All that we will discuss now. In case of ventricular tachycardia, first and foremost, very important criteria is that the heart rate, it should be more than 100 beats per minute. Right? The heart rate, it should be more than 100 beats per minute. And in case of this ventricular tachycardia, there should be 3 or more consecutive beats. Right? There are 3 or more consecutive beats. That is what exactly is the definition of your VT. Now, what is idioventricular rhythm? Idioventricular rhythm is that particular rhythm which is originating from the ventricle. But remember, 3 or more consecutive beats at slower rate, they are designated as the idioventricular rhythm. So, 3 or more consecutive beats, but at slower rate. That is what is called as the idioventricular rhythm. So these 3 or more consecutive beats, they are nothing but your premature ventricular contractures. Then what is non-sustained VT and as well as the sustained VT? VT or ventricular tachycardia that terminates spontaneously within 30 seconds, that is designated as non-sustained VT. So the one that terminates within 30 seconds, that is what is called as non-sustained VT. Whereas you take sustained VT. Sustained VT is that persists for more than 30 seconds. Right? For more than 30 seconds. That is what is called as sustained VT. Or the other definition of the sustained VT is that number one, it should persist for more than 30 seconds, or it is terminated by active intervention. Right? Terminated by active intervention. Okay, so that is what is your sustained VT. What do you mean by this active intervention? Like administration of the intravenous anti-arrhythmic drugs, or application of the external cardioversion, or pacing, or a shock from implantable cardioverter defibrillator. So that is what is nothing but your active intervention. So with active intervention, the VT, if it gets terminated, we call it as the sustained VT. Now let me just show you one of a ECG of the non-sustained VT. So this is the ECG of the non-sustained VT. See, in case of non-sustained VT, what is happening? Within less than 30 seconds duration, right? Within less than 30 seconds duration, the VT, it is getting terminated to normal sinus rhythm. Right? It is getting terminated to normal sinus rhythm. That is what is called as the non-sustained VT. Alright. Now, even if you take this VT, we have monomorphic VT and as well as the polymorphic VT. Now, what do you understand by the word the monomorphic VT? See, one definition of ventricular tachycardia is sustained as well as non-sustained VT. And the other type of ventricular tachycardia classification is monomorphic and as well as polymorphic ventricular tachycardia. Now, let me just show you the ECG of, let me just show you the ECG of monomorphic VT. So monomorphic VT, it is similar to that of unifocal premature ventricular contracture. So monomorphic VT, it has same QRS complex from beat to beat, indicating that the activation sequence is the same from beat to beat and that each beat likely originates from the same source. That is what is called as monomorphic VT. So monomorphic VT is the one which has the same QRS complex. Right, it is the one which has the same QRS complex from beat to beat. That indicates that the activation sequence is from the same focus within the ventricle. Then you take polymorphic VT or polymorphic ventricular tachycardia. Polymorphic ventricular tachycardia, this is the ECG of the polymorphic ventricular tachycardia. In case of polymorphic ventricular tachycardia, there will be tachycardia. There will be abnormal QRS complexes of differing morphologies, right? Abnormal QRS complexes of differing morphologies. That tells that the origin of the impulse is from multiple sites within the ventricle. That is called as the polymorphic ventricular tachycardia. Now, then followed by that, we have another important terminology called the ventricular flutter. Now, what do you mean by this particular word, the ventricular flutter? See, this is the strip of the ventricular flutter. So, in ventricular flutter, you have the presence of this flutter waves, right? And this ventricular flutter, let me tell you, it is one of the very close differential diagnosis for your ventricular tachycardia. Right? Now, then followed by that, you should know whether this particular ventricular rhythm, whether it is originating from right ventricle or whether it is originating from the left ventricle. That means you should know whether it is right ventricular tachycardia or whether it is left ventricular tachycardia. That is what you need to understand by seeing that particular ECG of the VT. Now, how to make out whether it is the right ventricular tachycardia? Let me explain you. Now, you take this particular ECG strip. This is the arrhythmia which is originating from the right ventricle, or it is the septum. Now, how can you tell that? The arrhythmia that originates from the right ventricular septum result in late activation of the left ventricle because the abnormal impulse originates within the right ventricle. So initially the right ventricle will get activated, then followed by that there will be later activation of the left ventricle, and thereby how will be the ECG complex? You will have a prominent or dominant S wave in V1 because you have the electrode at this place, and if you take the electrical activity is initially towards your right ventricle. So you will have a dominant S wave in lead V1, right? You will have a dominant S wave in lead V1, and it is similar to that of your left bundle branch block like configuration. So in case of right ventricular tachycardia, you will have prominent S wave in V1. That is one of the very important point you need to know. Now, for suppose if you want to make out that the arrhythmia is originating from the left ventricle, how will you make out? In case of left ventricular origin of ventricular tachycardia, you will have the presence of positive deflection. Right? You have the presence of positive deflection in V1. So you have the presence of dominant R wave in V1. right? You have the presence of dominant R wave in V1. So that is what is the arrhythmia that originates from the free wall of the left ventricle, where the individual will have a prominent positive deflection in V1, thereby producing a right bundle branch block like configuration in V1. But it is not RBBB. It is RBBB like morphology in V1. So very simple to classify. In case of right ventricular tachycardia, you will have LBBB like configuration. In case of left ventricular tachycardia, you have RBBB like morphology in V1. Then followed by that, now you have the ventricle. Ventricle, it has a base and it has the apex. Now from which part of the ventricle the impulse is originating? That abnormal ventricular rhythm is originating. So how will you make out? See, one point I have said you, whether the abnormal ventricular rhythm, is it originating from right ventricle or is it originating from the left ventricle? I have taught you. Now let me discuss, where is that abnormal rhythm originating from? Is it from the base of the left ventricle or is it from the apex of the left ventricle? So how will you make out? Let me discuss. And for that, you need to look for the frontal plane axis of the QRS morphology. So the frontal plane axis of the QRS is also useful. So how will you make out from this? Let me tell you. See, an axis that is directed inferiorly. How can you make out that the axis is directed inferiorly? It is indicated by dominant R wave in lead 2-3 AVF. Right? You see here, you have the presence of dominant R wave in lead 2-3 AVF. This will suggest the initial activation of the cranial portion of the ventricle. See, this is your ventricle. So out of which this is the cranial portion of the ventricle, and as well as this is caudal or the apex of the ventricle. So how can you make out that the origin of impulse is from the cranial portion of the ventricle? That is when, if you have a dominant R wave in 2-3 AVF, you see here 2, 3, like you have the dominant R wave. So the presence of dominant R wave tells you that the initial activation is from the cranial portion of the ventricle. Whereas if you want to make out that the frontal wave axis or the origin of the impulse is from the caudal portion, then in such case the frontal plane axis that is directed superiorly, you will have dominant S wave in lead 2-3 AVF, suggests that the initial activation is from the inferior wall. So very simple to remember. If it is like from the cranial portion of the ventricle, you will have the presence of dominant R wave in 2-3 AVF. Now, if the presence of the dominant S wave is there in 2-3 AVF, that tells the origin of the impulse, abnormal ventricular rhythm, is from the inferior wall. So, until now whatever I have discussed is definition of VT, what is monomorphic and polymorphic VT. Then followed by that, I have taught you how to differentiate whether it is right ventricular or left ventricular VT. Then I have also said you how to differentiate whether it is the superior or whether it is cranial origin or whether it is the inferior wall origin. So all that I have discussed in this particular section until now. Now let me tell you about the ventricular flutter. So I was showing you the ECG of ventricular flutter. So the ventricular flutter, it is very rapid monomorphic VT, right? Very rapid. Right? Very rapid monomorphic VT that has a sinusoidal appearance. That is called as ventricular flutter, because it is not possible to distinguish the QRS from T wave. And ventricular flutter, what did I tell you? It will be a very close differential diagnosis from your ventricular tachycardia. Right? Next. And you take the sinusoidal VT. That is relatively slow sinusoidal VTs, they have wide QRS morphologies. Right? They have wide QRS morphologies indicative of slowed ventricular conduction. See, in case of your ventricular arrhythmias, why is that you have wide QRS complexes? Because the abnormal impulse whichever is originated within the ventricle is not passing through the normal conducting system of the heart. It is passing through the abnormal ventricular myocardium or abnormal ventricular muscle, and that is what is responsible for slow conduction of the impulse, and that will have the wide QRS complex. Now, what are the etiologies for your ventricular flutter? Like hyperkalemia, that is electrolyte abnormalities. And the next important point is the drug toxicity. So, the drug toxicity with class 1 anti-arrhythmic drugs, that is your flecainide, and the other anti-arrhythmic drugs like propafenone, or the drug toxicity with tricyclic antidepressants. And not only that, even in case of very severe global hypokinesia, right, very severe global hypokinesia. So in all these conditions, the individual can have this ventricular flutter. Now, after having discussed about the ventricular flutter, let me tell you what exactly is the definition of polymorphic VT. Already I have shown you the ECG of polymorphic VT also. What is that the individual will have? The individual will have a continuously or continually changing QRS morphology. Right? Continually changing QRS morphology, indicating a changing ventricular activation sequence. That means in polymorphic VT, the ventricular activation impulse is not from the same focus. It is from different focuses within the ventricle. And if you take the etiology of your polymorphic VT, we have congenital causes. That is congenital long QT syndrome, that is responsible for the polymorphic ventricular tachycardia. And in this congenital long QT syndrome, these individuals, they can progress to torsades de pointes. And in this particular clinical condition of torsades de pointes, there will be twisting about the points of the QRS axis. So there will be twisting of the baseline. So in few complexes, the QRS complexes will be positive, and in few other complexes, the QRS complexes will be negative. So that is what you will have in polymorphic ventricular tachycardia, right? Which is nothing but which can progress to, or your torsades de pointes and polymorphic ventricular tachycardia is one and the same. But for the development of torsades de pointes, mainly electrolyte abnormalities like hypokalemia, hypocalcemia, hypomagnesemia can cause long QT interval, can progress to polymorphic ventricular tachycardia. Then congenital long QT syndrome, that is Jervell and Lange-Nielsen syndrome, right? So these are like, the congenital long QT syndromes, okay, right? Then followed by that, let me tell you about the ventricular fibrillation. So until now, we have discussed premature ventricular contraction, ventricular tachycardia, ventricular flutter. Then let me discuss about the ventricular fibrillation. Ventricular fibrillation, it has continuously irregular activation with no discrete QRS morphology. And in ventricular fibrillation, the ventricular rate will be more than 300 to 400 per minute. And there is no proper QRS morphology, right? There is no discrete QRS morphology, right? And it is mainly polymorphic VT that can make the individual to progress to the development of the ventricular fibrillation. Okay, I'll just show you the ECG of ventricular fibrillation. So this is the ECG of the ventricular fibrillation. So in case of ventricular fibrillation, let me tell you, they will have the abnormal QRS morphologies, and the QRS morphology you cannot identify. That is what you will have in ventricular fibrillation. Now, in this session, let me take up the discussion of ventricular tachycardia, AIVR, that is accelerated idioventricular rhythm, and ventricular fibrillation in detail. So in the previous session of mine, I was discussing about the premature ventricular contractures in detail. Now in this session, I will take up the ventricular tachycardia. So you see this multiple choice question. In a patient with wide complex tachycardia, the presence of all of the following in the ECG indicates ventricular tachycardia except. The options are atrioventricular dissociation, fusion beats, typical right bundle branch block, the capture beats. Now, the answer to this question is the typical right bundle branch block pattern will not be there in case of the ventricular tachycardia. Right? And what about the other options? I will discuss that in detail. So, if you take this ventricular tachycardias, they are like your ventricular ectopics. They originate from the ventricle, but the discharge is continuous and rapid. And what exactly is the definition of ventricular tachycardia? I have taught you. It is defined as a series of 3 or more consecutive ventricular ectopics, and they are recorded in rapid succession. That is what is the definition of your VT. And already I have taught you about sustained as well as non-sustained VT. And if the VT, if it is persisting for more than 30 seconds, it is sustained VT. And if it is terminating spontaneously, then it is designated as the non-sustained VT. Now, for the ventricular tachycardia, there are certain characteristic features. These characteristic features include AV dissociation, capture beat, fusion beat, Josephson sign, and as well as the Brugada sign. Now, these are the characteristic features, and let me discuss in detail about these particular characteristic features of your ventricular tachycardia. Now, I will just show you one ECG. Yes. So please identify what exactly is this particular ECG of. This particular ECG, it is having a broad complex or broad QRS complex tachycardias. And these broad QRS complexes, if you observe closely in an individual lead, they are of similar morphologies. So this is suggestive of monomorphic, right? Monomorphic sustained ventricular tachycardia, right? Monomorphic sustained ventricular tachycardia. Now, in this, you should tell me whether it is the right ventricular VT or the left ventricular VT. Very simple. What did I tell you? In case of the right ventricular VT, the individual will have the left bundle branch block pattern. That is, in right ventricular VT, you will have the presence of the prominent S wave. So, you see here, in case of the V1, you have the presence of the prominent S wave. Right? You have the presence of a prominent S wave in V1. So, what is this VT now? It is a monomorphic sustained VT of right ventricular origin, right? Of right ventricular origin. So this is about the monomorphic VT. Now let me discuss about the characteristic features of VT. What did I tell you? That is capture beat, fusion beat, Josephson sign, Brugada sign, and AV dissociation. Now let me show you that. In case of patients with VT, you have the fusion beats and you also have the capture beats. Now what is your fusion beat? The fusion beat is that in case of ventricular tachycardia, you have abnormal QRS complex. And you take in a sinus beat, you have the normal QRS complex. So if at a time, the sinus impulse which is coming from the sinus node and ventricular impulse which is coming from the ventricle, if both of them they fuse, they will result in what is called the fusion beat. So in case of the fusion beat, the QRS complex is wide and appears as something between the ventricular beat and as well as the normal beat. That is what is called as the fusion beat. Whereas you take the capture beat. In case of the capture beat, the beats they resemble the normal sinus rhythm. But these beats are presumably supraventricular beat that manage to get through and depolarize the ventricle, and they are called as the captured beat. And please remember that these beats display a large Q waves. That means in case of captured beats, what happen normally, in the sense abnormally, in case of ventricular tachycardia, it will be ventricular rhythm only. This fast originating ventricular rhythm, they will suppress the sinus rhythm whichever is coming. But occasionally the sinus beat will capture the ventricle. The sinus beat will enter into the ventricle before the origin of the ventricular abnormal impulse, and thereby you will have a normal QRS complex in between this ventricular tachycardia rhythm. And this is what is nothing but the captured beat. There, the captured beat, they have the presence of the deep S wave, right? They have the presence of deep S wave. Now, apart from that, let me tell you, in case of the ventricular tachycardia, right? In case of ventricular tachycardia, you have wide QRS complex. You see here, this is your wide QRS complex. So what do you mean by this word wide QRS complex? It is that when the QRS morphology, if it is more than 120 milliseconds, we call it as wide QRS complex. Second, you will not have right bundle branch block pattern or left bundle branch block pattern. Right? In case of SVT with aberrancy, there you can have RBBB or LBBB morphology. Right? Whereas in VT, you can see this is your right ventricular VT. What is that you will have? You will have a prominent S wave in V1, but you will not have the similarity to that of the left bundle branch block pattern morphology. And if you take the axis in these individuals, right? So lead 1, it is negative, and lead 2, it is also negative. So both are negative. So this is what is nothing but your extreme axis deviation. Right? This is what is nothing but your extreme axis deviation, or it is also called northwest axis. And the P wave and QRS complexes, they are at different rates. In fact, you don't have a particular P wave in this particular ECG of the rhythm strip. So that tells you there is AV dissociation. So AV dissociation, the P wave and as well as the QRS complexes, they are at different rates. Then coming to the captured beat and fusion beat, already I have discussed that they are also the features of your ventricular tachycardia. Now, the other important two signs are Brugada sign and as well as the Josephson sign. They are also the features of your ventricular tachycardia. Now, let me show you that Brugada sign and as well as the Josephson sign. Yes. So, what exactly you mean by this word Brugada sign? See, in case of the Brugada sign, the distance from the onset of the QRS complex to the nadir of the S wave, it should be more than 100 milliseconds. So you see here, this is the start of the QRS complex, and this is the nadir of the S wave, and this particular distance, it should be more than 100 milliseconds. That is what is called as Brugada sign. And we also have what is called Brugada syndrome. See, Brugada syndrome is different. Brugada syndrome, it is a sodium channel defect where there will be defect in the gene SCN5A. And in these patients with the Brugada syndrome, you have the coved ST segment elevation in V1 and as well as V2. And these patients with the Brugada syndrome, they can have sudden cardiac death. And these patients with the Brugada syndrome, the treatment of choice is implantable cardioverter defibrillator. So Brugada syndrome is different from the Brugada sign. Then coming to your Josephson sign. What is this Josephson sign? Josephson sign, it is notching near the nadir of the S wave. See, this is your S wave. So exactly at the nadir of the S wave, you have the presence of notching. That is what is called as the Josephson sign. And I have already said you in case of ventricular tachycardia, you don't have the RBBB or the LBBB morphology. And I have said you about the presence of the fusion beats. So what is this fusion beat? At times, the capturing rhythm may reach the ventricle concomitantly. That is ectopic ventricular impulse and as well as the sinus rhythm, both of them they reach the ventricle concomitantly. When this occurs, each impulse will activate the part of the ventricles. Sinus rhythm will activate a part of the ventricle and the ventricular impulse will activate the part of the ventricle. And the resulting QRS complex will have the configuration that is what is called as the fusion beat. So this is like in between the pure sinus beat and as well as a pure ectopic beat. That is what is your fusion beat. Okay, then I have also said you about the capture beat. So what is this capture beat? Occasionally with sometimes during the critical timing and especially during relatively slow ventricular tachycardia, a sinus impulse, right? A sinus impulse may reach the AV node during a non-refractory phase. That is just after the period of absolute refractoriness. Then once this sinus impulse reaches the ventricle, the sinus impulse will capture that particular ventricular beat and that is what is called as the capture. So it is the sinus impulse that can be conducted to the ventricle and momentarily activate or capture the ventricle for one beat only. That is what is called as the captured beat. And this conducted beat which occurs during the ectopic ventricular rhythm is known as the capture beat. Right? It is known as the capture beat. Then followed by that, we will go back to the question what we were discussing previously. In a patient with wide complex tachycardia, the presence of all of the following in the ECG indicates ventricular tachycardia except atrioventricular dissociation, fusion beat, typical right bundle branch block, the capture beat. So the answer to this question is the typical right bundle branch block will not be there in ventricular tachycardia. AV dissociation can be there, fusion beat can be there, capture beat can be there, but the typical right bundle branch block pattern will not be there. So this is the summary of your VT. If you take the rate of the individual, it should be more than 100. And it can be more than 200 also, but it is usually rare. It can be there, but it is usually rare. And if you take the rhythm, most of the times it will be irregular. Occasionally it can be a regular rhythm as well. And you take the P waves are usually absent because the rhythm is the ventricular rhythm there. So thereby you have only a broad QRS complexes. You will have a P wave only when there is presence of a capture beat which is nothing but a sinus beat. And you take the QRS morphology. The QRS morphology, you have a broad QRS complex, right? You have a broad QRS complex, but you will not have either right bundle branch block pattern or left bundle branch block pattern will not be there. And the other features of VT like AV dissociation, fusion beats and as well as the capture beats, they are all present in your ventricular tachycardia. Now, you see one particular question related to your ventricular ectopics. So ventricular ectopic beats are represented by irregular RR interval, incomplete compensatory pause, AV dissociation, presence of the fusion beat and the wide QRS form. Remember, in ventricular ectopic beats, you will not have the incomplete compensatory pause. There will be a complete compensatory pause in case of ventricular ectopic beat. The remaining all are present in ventricular ectopic beats. Irregular RR interval is there, AV dissociation is there, presence of fusion beat is there, and there can be presence of the wide QRS complex. Now, after having discussed about the ventricular tachycardias in detail, the characteristic features of the ECG, let me discuss the treatment of ventricular tachycardias. For suppose I have a patient with heart failure he has developed the ventricular arrhythmia. A patient with heart failure developed ventricular arrhythmia. What is the treatment? Encanate, flecainate, intracardiac defibrillator, beta blocker, amiodarone. So, ventricular arrhythmias, they are usually associated with the heart failure. Now, which all ventricular arrhythmias can be associated with the heart failure? With heart failure, there can be premature ventricular contracture. There can be asymptomatic ventricular tachycardia. There can be even ventricular fibrillation. So, these ventricular arrhythmias can be associated with your heart failure. Now, how will you manage? Management of arrhythmias associated with heart failure include, number one, you need to do the correction of electrolyte or acid-base disturbances if at all if present. And the second important point is the first line therapy in case of the ventricular arrhythmias associated with heart failure, you need to give beta blockers. Right? And the beta blockers that can be given is your metoprolol. So, beta blockers are the first line of therapy in patients with ventricular arrhythmias in case of the cardiac failure. Right? In case of the cardiac failure. So, this is about the beta blockers. Right? These are the first line of therapy in patients with the ventricular arrhythmias in case of the cardiac failure. Now, in patients with documented sustained ventricular tachycardia, an implantable cardioverter defibrillator is highly effective in treating the recurrences of these arrhythmias. And this implantable cardioverter defibrillator, it has anti-tachycardia pacing or cardioversion defibrillator. So this anti-tachycardia pacing, this can reduce the morbidity and this will also reduce the need for hospitalization. So that is what is the treatment for documented sustained ventricular tachycardia. Because in case of sustained ventricular tachycardia, the individual can land up in sudden cardiac death. For suppose, if the individual, so in which group of individuals you require this implantable cardioverter defibrillator? Like you take in patients with the Brugada syndrome, right? You take in patients with the congenital long QT syndrome. So in these individuals, the ventricular tachycardia can progress to ventricular fibrillation. That can progress the individual to land up in sudden cardiac death. In those individuals, you require an implantable cardioverter defibrillator. And what exactly is the drug of choice in case of your VT? Remember, the drug of choice in case of a stable VT. Now, what do you understand by this word stable VT? Stable VT in the sense the individual is hemodynamically stable. Right? The individual is hemodynamically stable. So, when the individual is hemodynamically stable, you can give medical management in case of ventricular tachycardia, and that particular drug of choice is lignocaine. Right? Drug of choice is lignocaine. And the other drug which can be used as a maintenance therapy for ventricular tachycardia is your amiodarone. Amiodarone is useful in all the types of arrhythmias. Even it can be given in atrial fibrillation also. It can be given in VT. It can be given in ventricular fibrillation. Right? So, amiodarone, it is useful in all the types of arrhythmias. Okay, and it is also the treatment of choice in patients with atrial fibrillation and heart failure, and it is also quite effective in case of the ventricular tachycardias as well. What is the advantage of the amiodarone? Why is it useful in all the types of arrhythmias? Because the added advantage of amiodarone is that it has a very minimal cardiodepressant action, and that is the reason why amiodarone is effective in all the types of the arrhythmias. So if you take the drug of choices in the individual arrhythmias, you see this particular table which is very important for you. So if you take this table, in a case of narrow QRS complex supraventricular tachycardia, the drug that can be given is verapamil or beta blocker. And if it is like wide complex supraventricular tachycardia, you need to give flecainide. And in WPW syndrome associated with atrial fibrillation, drug of choice is flecainide. Whereas in PSVT, paroxysmal supraventricular tachycardia, the drug of choice for acute treatment is your 6 milligrams of adenosine. No response, give 12 milligrams. If there is no response, repeat one more dose of 12 milligrams of your adenosine. If further there is no response, you can give beta blocker or calcium channel blocker. And for PSVT for prophylaxis and for PSVT as a part of maintenance therapy, you need to give calcium channel blocker, that is verapamil can be given. And this verapamil, it is a non-dihydropyridine calcium channel blocker. And in case of digitalis induced ventricular tachycardia, the drug of choice is the lignocaine. And in case of torsades de pointes, the drug of choice is the magnesium sulfate. So, if you see the question now, we were discussing a patient with heart failure developed ventricular arrhythmia. What all the treatments can be given? You can give implantable cardioverter defibrillator if the individual is having congenital syndromes which can progress the individual to ventricular tachycardias or ventricular fibrillations. Then beta blockers, they are the first line drugs. Then amiodarone can be given in all the types of arrhythmias because amiodarone, it has a very minimal cardiodepressant action. That is the reason why amiodarone can be preferably given. Let me see, I have given you the summary of your VT, ventricular tachycardia. But if you just see the summary of monomorphic VT, what did I tell you? In case of monomorphic VT, the individual will have QRS complexes of similar morphology, and that can be sustained and that can be non-sustained. If it is sustained, it is more than 30 seconds or it requires an active intervention to terminate that particular rhythm. If it is non-sustained, the arrhythmia is present for less than 30 seconds. So that is what is your sustained and as well as non-sustained VT. Now what is the clinical significance of this particular monomorphic VT? The ventricular tachycardias may impair the cardiac output with consequent hypotension, collapse and acute cardiac failure. And this is due to extreme heart rates and lack of coordination of the atrial contraction. There will be loss of the atrial kick. So what is the clinical significance of your VT? The clinical significance is that the individual can present to you with the history of palpitations or the individual can present to you with the history of syncopal attack. And why is that? There will be decrease in the cardiac output. So because of decrease in the cardiac output, what will happen to your cerebral perfusion? Cerebral perfusion decreases. As the cerebral perfusion decreases, there will be transient loss of consciousness that makes the individual to land up in a syncopal attack. Okay. So what is the mechanism? The most common mechanism for the development of your VT is re-entry. Actually, for the arrhythmias to develop, we have three important mechanisms that we have discussed in the introductory part of the arrhythmias. One is your re-entry phenomenon. The other one is triggered activity. And the other one is the abnormal automaticity. So here the mechanism is the re-entry phenomenon. Right? The most common mechanism is re-entry phenomenon. And ECG, what did I tell you in case of monomorphic VT? They have uniform QRS complexes. Right? They have uniform QRS complexes. Okay? So that is about your monomorphic. So this is the ECG of the monomorphic VT. And how do you treat these individuals of monomorphic VT? In case of monomorphic VT, if the left ventricular function is impaired, amiodarone, it is preferred over the procainamide. So why is this procainamide not preferred then compared to that of amiodarone? Because this procainamide, it has the potency or it has the potential for exacerbating the heart failure. Right? It has the potential for exacerbating the heart failure. Right? And if the medical therapy is unsuccessful, then synchronized cardioversion, that is 50 to 200 joules monophasic shock following the sedation, is very much appropriate. So sedate the patient, then you give synchronized cardioversion. If the medical therapy is unsuccessful or if the individual has pulseless VT, that means hemodynamically unstable VT, these patients, they require immediate defibrillation and high dose unsynchronized energy should be used. And this particular high dose unsynchronized energy is around 150 to 200 joules. And it is a biphasic shock, right? So, very simple. Stable VT, first initially give medical management, amiodarone, and the drug of choice is lignocaine. And not responding to medical management, or if it is like unstable VT, unstable monomorphic VT, do synchronized cardioversion, right? Or if it is like hemodynamically unstable or pulseless VT also, we do the same thing, unsynchronized cardioversion. So the next important thing, let me discuss about the ventricular storm or the electrical storm. See, this is another very important emergency of the ventricular arrhythmias. What is this ventricular storm or electrical storm? Ventricular storm or electrical storm is that when the number of episodes of ventricular tachycardia, right, when the number of episodes of ventricular tachycardia, if they are like more than 3 per day, right, if they are like more than 3 per day, that is what is called as the electrical storm or the ventricular storm. Now, first of all, these patients, you have to adequately sedate the patient before the treatment, and you need to reduce the anxiety levels of these individuals. And how do you treat these patients? Let me tell you, they are treated with standard advanced cardiac life support guidelines according to the advanced cardiac life support guidelines. So, how do you treat these patients with the electrical storm? The treatment of electrical storm, you need to follow the treatment guidelines according to the advanced cardiac life support. And in this ACLS guidelines, you will be using the medications such as beta blockers, amiodarone, lidocaine with correction of any metabolic abnormality whichever is present. So that is what is the medical management for the ventricular storm. And these patients with the ventricular storm, if the medical management fails, in such case, right, in such case, the general anesthesia should be considered for suppression of recurrent hemodynamically unstable ventricular arrhythmias. Right, for the treatment of recurrent hemodynamically unstable ventricular arrhythmias, you need to sedate the patient. And apart from that, the cardioversion is another important line of treatment. And please remember this very important point. When you do a left stellate ganglion block and upper thoracic epidural anesthesia, they will reduce the cardiac sympathetic outflow. Right, they will reduce the cardiac sympathetic outflow, and they have been used to restore the stability in some patients. Right, they have been used to restore stability within some patients. So that is what is the treatment for your ventricular storm. And so what is that I have just summarized? That is monomorphic ventricular tachycardia. And if you take the summary of the polymorphic ventricular tachycardia, so I said you the etiology of polymorphic ventricular tachycardia. They are usually the progression of the long QT syndromes. What is that congenital long QT syndromes? They are like Jervell and Lange-Nielsen syndrome and as well as the Romano-Ward syndrome. In case of Jervell and Lange-Nielsen syndrome, you also have the presence of the sensory neural deafness. And the other causes for polymorphic ventricular tachycardia is Brugada syndrome and even your Takotsubo cardiomyopathy. See, Takotsubo cardiomyopathy is the disorder where you have excessive stress. It is also called stress cardiomyopathy, or it is also called apical ballooning syndrome, or it is also called broken heart syndrome. That is what is called as Takotsubo cardiomyopathy, where the individual can have the polymorphic ventricular tachycardia. And the drugs which can predispose to long QT interval that can progress to polymorphic ventricular tachycardia is Class 1A anti-arrhythmic drugs, that is quinidine, procainamide and as well as the disopyramide. Class 1C anti-arrhythmic drugs like incanide and as well as the flecainide. And class 3 agents like sotalol and as well as the amiodarone. So these are the drugs which can predispose to long QT interval and as well as polymorphic ventricular tachycardia. And the other thing is the antihistamines like astimazole and the terfenadine, they can also make the individual to progress to Torsades de Pointes. And if you take the features, they require the long QT interval to progress to polymorphic ventricular tachycardia, and the ECG will show the morphology of the QRS complexes which vary from beat to beat, right? Which will vary from beat to beat. So that will be the ECG of the polymorphic ventricular tachycardia. Then, how do you treat these patients? If this polymorphic ventricular tachycardia is due to consequence of long QT interval, then the drug of choice will be magnesium sulfate. Right? The drug of choice will be magnesium sulfate. Now, what does this magnesium sulfate do? Magnesium, it will terminate the arrhythmia by decreasing the influx of the calcium and thereby lowering the amplitude of the early after depolarization. That is what is the treatment of the ventricular arrhythmias of polymorphic origin or polymorphic ventricular tachycardias. And the other important line of treatment that can be given in case of polymorphic ventricular tachycardia is isoproterenol. See, isoproterenol, it accelerates the AV conduction and decreases the QT interval by increasing the heart rate, and thereby it reduces the temporal dispersion of repolarization. And please remember, in case of the congenital long QT syndromes, the beta adrenergic agonists such as the isoproterenol, they are contraindicated. Right? They are contraindicated. So this is about your ventricular tachycardia. So ventricular tachycardia, mainly you need to do two forms, monomorphic and as well as polymorphic. And you need to know whether it is right ventricular or left ventricular origin. And you need to know whether it is sustained or non-sustained. And in case of VT, you will have AV dissociation, capture beat, fusion beat, Brugada sign, Josephson sign. This should be there. And in VT, the heart rate should be more than 100. It can be more than 200 also, but it is usually rare. The drug of choice for VT, stable VT, lignocaine, and maintenance therapy, amiodarone. And if it is associated with heart failure, the first line therapy you can add even beta blocker. And if it is associated with congenital long QT syndromes, then you need to put the patient on implantable cardioverter defibrillator. So this is like summary of your VT. Then the another important type of your ventricular rhythm is accelerated idioventricular rhythm. Now you see this question. Accelerated idioventricular rhythm is most characteristically seen in AV nodal block, myocardial reperfusion, metabolic derangement, and then digitalis therapy. Now, let me just show you the ECG of the AIVR, and I will also discuss the etiology of the AIVR. So, AIVR stands for accelerated idioventricular rhythm. This is the ECG of the AIVR. If you take the rhythm AIVR, it has an absolutely regular rhythm. See, you take the RR interval, right? The individual will have a regular RR interval. But how will you differentiate this? Even here also, you have like broad QRS complex. Right, here also you have the broad QRS complex, where the QRS complex is like more than 120 milliseconds. Right, where the QRS complex is like more than 120 milliseconds. But how will you differentiate this from VT? How will you differentiate this from VT is the rate if you take, it will be 50 to 110 beats per minute. right? 50 to 110 beats per minute. So that will be the features of the accelerated idioventricular rhythm, right? And these individuals, they can also have the fusion beats and as well as the capture beats, right? As well as the capture beats. Okay, next, now in case of accelerated idioventricular rhythm, most of the time it is a self-limiting arrhythmia. It is a arrhythmia with benign rhythm, right? And it is believed to be caused by abnormal automaticity, right? It is believed to be caused by abnormal automaticity, and it is considered to be a brief self-limiting arrhythmia. And this AIVR, they do not usually require any specific treatment. Only if the individual is like symptomatic, then we give the treatment for AIVR. Otherwise, your AIVR, it is absolutely a benign rhythm, right? Absolutely, it is a benign rhythm. Okay. Next, the other important thing is, what are the etiologies of your AIVR? This AIVR, it is a characteristic feature of the myocardial reperfusion. After the thrombolytic therapy in patients with MI, you can have this particular AIVR. So there is a presence of a thrombus in MI that will block the vessel and that will cause the death of the myocardium. And you have given a thrombolytic therapy and you have lysed that particular thrombus and you have opened the coronary artery, right? You have opened the vessel, then there will be myocardial reperfusion. So your AIVR is a characteristic feature of myocardial reperfusion. When this myocardial reperfusion occurs in the setting of the myocardial infarction, that can make the individual to develop this particular accelerated idioventricular rhythm. So this AIVR, it is also called reperfusion arrhythmias or reperfusion rhythm, right? It is also called reperfusion arrhythmia or reperfusion rhythm, and it commonly occurs at the moment of reperfusion of the occluded coronary artery. That is what is your the AIVR, accelerated idioventricular rhythm. And let me tell you, this AIVR can be seen even in the absence of any structural heart disease, but it is usually seen in patients who have an underlying structural heart disease. Those individuals who have an underlying structural heart disease, you will have this AIVR. But let me tell you, this AIVR can occur even in the absence of any particular structural heart disease. Now, what are all the various causes of AIVR? Number one, it is your myocardial reperfusion. And apart from that, even your cardiomyopathies, like you take dilated cardiomyopathy, ischemic cardiomyopathy, can also cause this AIVR. And the other etiologies include acute myocarditis and as well as the rheumatic heart disease. So these are the etiologies for your AIVR. And not only that, even your digitalis intoxication. So with digitalis intoxication, you can have all the type of arrhythmias except your atrial fibrillation, except your atrial flutter, except your Mobitz type 2 AV block. And not only digitalis intoxication, even cocaine intoxication. The individual can have this AIVR, right? Next. Now, these arrhythmias, they are common after the reperfusion. And the most common post-reperfusion arrhythmia, if it is asked, the answer should be AIVR, that is accelerated idioventricular rhythm. Please remember, this is a very, very important point. It's a benign rhythm. It's self-terminating. You don't require to give any treatment. And what will be the rate? I have already just now said you, it will be around 50 to 110 or 120 beats per minute, but most of the time it is less than 100 per minute. Alright, next. Then followed by that, you take the features. Okay, regarding the treatment, what did I tell you? No specific treatment. But when will you give the treatment? Only when the individual is like symptomatic, you need to give the treatment. So, what is that particular treatment you need to give? So, you see this here. Symptomatic patients with hemodynamic compromise, they require the treatment. And if you take the treatment, atropine or the atrial pacing, they will suppress this accelerated idioventricular rhythm by simply increasing the sinus rate. And even lignocaine may be used for the suppressive therapy. So this is about your AIVR, that is accelerated idioventricular rhythm. So to summarize the three types of arrhythmias we have discussed until now, you take the premature ventricular contracture. It is the one where the origin of the impulse is from the ventricle, but that appears before the next anticipated supraventricular beat. That is what is your premature ventricular contracture. And I have discussed about unifocal and as well as multifocal. Ventricular tachycardia definition is 3 or more consecutive premature ventricular contractures and the rate faster than 100 beats per minute, we call it as ventricular tachycardia. It could be sustained or non-sustained. Sustained VT more than 30 seconds or terminated by active intervention. Non-sustained VT less than 30 seconds, self-terminating. Then AIVR. AIVR, you have 3 or more consecutive ventricular premature contractures, but the rate is usually less than 100 per minute. So that is about your AIVR. So if you take this question, AIVR is most commonly seen in myocardial reperfusion. So after having discussed about the AIVR, let me tell you about this wide complex tachycardia. So what are these wide complex tachycardias? One is your VT, the other one is ventricular fibrillation, which I will be discussing now, and the other one is pre-excited arrhythmias. What are these pre-excited tachyarrhythmias? That is your WPW syndrome. And the other one is SVT with aberrancy. See, in case of WPW syndrome, we know that there will be presence of wide QRS complex and there will be presence of delta wave and they have short PR interval. Right? They have short PR interval. This already I have discussed. But how will you differentiate the ventricular tachycardia from SVT with aberrancy? What do you understand by this word SVT with aberrancy? Aberrancy means there is a bundle branch block. Right? Aberrancy means there is a bundle branch block. Either it is right bundle branch block or your left bundle branch block. That is what is nothing but SVT with aberrancy. Now, let me tell you the differences between the ventricular tachycardia and as well as the SVT with aberrancy. You take ventricular tachycardia, they have broad QRS complex. Even with SVT with aberrancy also you have broad QRS complex, but you take the QRS duration. In case of SVT, the QRS duration is more than 140 milliseconds. Whereas in SVT with aberrancy, you have 120 to 140 milliseconds. And you take the QRS pattern. In case of the VT, you will not have LBBB or RBBB pattern. But SVT with aberrancy, you will have the LBBB or the RBBB pattern. Then you take this particular P wave. What did I tell you in case of ventricular tachycardia? The P wave is obscured or the P wave is absent because the ventricular originating QRS complexes, they will suppress the atrial complexes. Only when there is presence of a capture beat in ventricular tachycardia, you can have the presence of P wave. Whereas you take the SVT with aberrancy, P and QRS rate and rhythm linked to the ventricular activation, it depends upon the atrial discharge. You can have the presence of the P wave in case of SVT with aberrancy. And QRS morphology, in VT, either it is monophasic or biphasic. But whereas in SVT with aberrancy, you will have triphasic QRS complex. Then the other important features are compensatory pause, fusion beat, capture beat, and the AV dissociation. All these are present in case of ventricular tachycardia. Usually, they are absent in case of the SVT with aberrancy. And if you do a vagal maneuvers, you can terminate the SVT with aberrancy. But vagal maneuvers, there is no effect of vagal maneuvers on ventricular tachycardia. So these, and next thing, if you take the R by S ratio in V6, it is less than 1 in VT and it is more than 1 in case of the SVT with aberrancy. Okay, so these are the differences between VT and as well as the SVT with aberrancy. Why am I telling you these differences is because both of them, they are the tachycardias with wide QRS complexes. Now, after having discussed about the ventricular tachycardia, let me give you a short description of the ventricular fibrillation. What did I tell you about ventricular fibrillation? It is the disorder where you have the abnormal QRS complexes. You don't have the morphology of the QRS complex cannot be exactly defined in case of ventricular fibrillation. So, ventricular fibrillation, if you see the mechanism first, it occurs in various clinical situations, but it is most commonly with the coronary artery disease as the terminal event. So, this ventricular fibrillations, most commonly it is associated with the coronary artery disease. And these patients with the ventricular fibrillation, they can progress to cardiac arrest, right? And in patients with the cardiac arrest and in patients with the commotio cordis, the most common identified arrhythmia is your ventricular fibrillation. And this ventricular fibrillation can occur during anti-arrhythmic drug administration also. And what is that particular anti-arrhythmic drug administration? That is class 1 anti-arrhythmic drugs. See, class 1 anti-arrhythmic drugs, you are having long QT interval and that can progress to polymorphic ventricular tachycardia. And this polymorphic ventricular tachycardia can progress to ventricular fibrillation. And this ventricular fibrillation can also occur during hypoxia, ischemia, atrial fibrillation, and very rapid ventricular rates in pre-excitation syndromes. So that is the etiology for your ventricular fibrillations. And what will be the ECG? I have already said you that they have irregular undulations of varying contour and amplitude. Let me show you the ECG of ventricular fibrillation. So this is the ECG of the ventricular fibrillation. You take the QRS complexes, right? They are of varying contour and varying amplitude, right? And these individuals, most of the time, they are hemodynamically unstable. Right? Most of the time they are hemodynamically unstable. And how do you treat this ventricular fibrillation? Okay, but before that, what is the mechanism? The mechanism for the development of ventricular fibrillation is, please remember this point, spiral wave re-entry. Spiral wave re-entry is the mechanism for the development of ventricular fibrillation. And the other important mechanism is multiple circulating re-entry. Multiple circulating re-entry wavefronts. Okay, so these are the mechanisms for the development of the ventricular fibrillation. Now, already I have said you one important point, that polymorphic ventricular tachycardia or monomorphic ventricular tachycardia, that can degenerate to ventricular fibrillation, and that would be the cause for your cardiac arrest also. And your treatment guidelines should be in the line of the advanced cardiac life support. So you can see my section of the emergency medicine where I have discussed the ACLS guidelines. Okay, and very important line of treatment in case of a hemodynamically unstable individual is you need to give non-synchronized DC electrical shock, and the dosage of this particular non-synchronized DC electrical shock, it should be in a range of 200 to 400 joules, and it is mandatory therapy for ventricular fibrillation. And following this particular shock, again you need to continue the CPR. You need to follow the ACLS guidelines. So please remember this: CPR, IV line anti-arrhythmic drugs, intubation. These are the mainstay of treatment in patients with your ventricular fibrillation. For suppose if the ventricular fibrillation returns back with your DC shock, your intubation and all is not required. But if the rhythm fails to return after 2 minutes of the chest compression, then you need to intubate the patient. So this is very important line of treatment. So in hemodynamically unstable ventricular fibrillation, defibrillation, that is DC shock, CPR, drug, and then DC shock, this has to be rotated until the rhythm of the individual is regained back. And the anti-arrhythmic drugs that can be given in ventricular fibrillation is lignocaine, amiodarone, magnesium sulfate, and procainamide. So please remember this mnemonic LAMP. These particular anti-arrhythmic drugs can be given in patients with the ventricular fibrillation. So these are some of the very important points related to your ventricular arrhythmias. So in this session we have discussed about VT, and as well as I have discussed about the ventricular fibrillation. Then I have also taught you about the ventricular stop. So with this I will conclude the topic of the ventricular arrhythmias. Thank you very much.